All right. Very good morning, everyone. Welcome to ISG Masterclass in yet another lecture on very important topic. Thank you very much, Paul, for joining masterclasses every time. And till now, we had a good experience of web streaming these masterclasses to our fellow gastroenterologists and physicians. As we know that we web stream masterclass in two platforms. One is ISG Masterclass and also on the Facebook Live. Those who you can watch on the Facebook also. For today, we have a very important topic. And as you know, Crohn's disease is a complex disease and its management is more or less personalized for every kind of patients. And we thought for this topic, we have a speaker who is so well known. He's Dr. Vineet Ahuja, who is a professor of gastroenterology at All India Institute of Medical Sciences. And he is one of the global authorities on IBD. His work, his publication, his understanding on this subject is remarkable. And being a colleague of him, I learn a lot from him almost everyday basis. So he will cover how do you treat patients with Crohn's disease. We have a purposefully not kept a differentiation between TB and Crohn's. Many of you might have a question on that, but we'll cover this topic of differentiating or different diagnosis of Crohn's disease in some other lecture series. So, and to moderate this session, we have requested Dr. Matthew Phillip, who is again very dear colleague. He is a head of department of gastroenterology at Ledgely Hospital in Cochin. He will moderate the session of this masterclass. With this few words, I hand over to Dr. Vivek Saraswat to welcome you once more and then invite Dr. Ahuja for this masterclass. Dr. Saraswat, please.
Thank you, Govind. Good afternoon, ladies and gentlemen. It's a great pleasure to welcome all of you who are attending this series of ISG masterclasses once again to this session this afternoon by Professor Vineet Ahuja on Crohn's disease. As you know, we started this series of lectures for our DMDNB residents when, due to the lockdown, usual academic teaching activities have been suspended in most departments. And it has been a most gratifying experience for all of us in ISG to see the large turnout and the enthusiastic response to this initiative. Your feedback, which you have provided, I think at the end of today's session, Dr. Govind will talk to you about what has been the feedback from all our audience. As Govind has pointed out, I've had the pleasure of knowing Vineet since his undergraduate days when I was doing my MD and DM at the All India Institute. And from day one, all his peers and his seniors identified him as a star in the making. And today, I think that star has risen and is shining on the firmament, as he's a man of many parts. Apart from Crohn's disease, he's also editing the journal Tropical Gastroenterology that you're all familiar with. A basic scientist who's doing a lot of community-related work on the human intestinal microbiome, a hot topic these days, and many other achievements which I know only a fraction of. Nevertheless, I think Govind has pointed out that you are in for a treat from a person who has been deep into the ins and outs of Crohn's disease. Now, as you're aware, the format will be the same as usual. That is, after about 20 or 25 minutes into the session, we'll take a break when the questions that you have sent to us on your chat box will be taken up, some of them, by Professor Matthew Phillip. And once Vineet has tackled those and has completed his talk, we'll take another set of questions towards the end of the session at 15 to 20 minutes, for about 15 to 20 minutes. And thereafter, I think Govind will briefly speak to you about the responses that we have had from the questionnaire that has been circulated for the last couple of weeks. Okay, without further ado, I will now request Professor Vineet Ahuja to begin his lecture on Crohn's disease. Vineet.
Thank you. Thank you, Professor Saraswat. Thank you, Govind. Thank you for a very kind introduction. I'm overwhelmed. Secondly, I would like to congratulate you for what has been not only an outstanding initiative, but a hugely successful initiative. It's really like your leadership, both of your leadership, has taken ISG to new fronts. So today we are going to discuss about Crohn's disease. So the scenario is a lifelong disease, chronic progressive disease, immunoinflammatory in nature. Therapy is generally immunomodulation, so it can control but not cure. So what does it tell you? That if you're going to treat this patient, then it's a lifelong journey along with the patient. If it is going to be a lifelong journey along with the patient, then it is very important that there are certain perspectives which you should know about the patient. And for that, I have made an initial checklist. This initial checklist may appear trivial. You may feel that why is it so important when it's related to management? But I think this is probably the platform. This is like the route map. This is something which will actually tell you in terms of any kind of patient who can come to you, because Crohn's disease can present with protein manifestations. So if you have this checklist in mind, you can actually treat any kind of patient. So what does this checklist consist of? First is that we define the disease. Second step is stratify whether it is an aggressive disease or not, a high risk disease or a low risk disease. Third is we decide what is the or select what is the appropriate therapy, and then there are certain rules for managing flares. So these are all general principles. So the first principle is defining the disease. So for defining the disease, you need to know the location, whether it is ileal, colonic, ileocolonic, or it is involvement of only upper small intestine. You need to define the dominant behavior, which could be inflammatory, stricturing, fistulizing, or perianal. You need to define the duration of the disease. Early disease, probably, if you act early, then probably the results would be better. We'll talk about it later. Age at onset may matter. And to consolidate all of this, we have what is known as Montreal classification. Now, is Montreal classification only important for research? Is it important only if you are putting in some data together, or it is something which you can use in your regular clinical practice? The answer out here is very clear. It is an identification tag for the patient. The patient is probably going to stay with you for many, many years. So you need an identification tag. You need a tag which would have an element of dynamicity in it, so that even if the identification pattern changes, still you can know from which point A to point B what aspects of the patient's phenotype changed. So that is why Montreal classification is very important, and every patient in your OPD should have been phenotyped according to Montreal classification, which is L1, involvement of terminal ileum with or without cecum, L2 is colonic, L3 is ileocolonic, L4 is upper GI tract, and then you have the behavior as I told you. B1 is inflammatory, B2 is stricturing, B3 is penetrating, and perianal is a modifier of the in terms of being perianal fistulizing disease. Now, here regarding phenotype, there are two concepts we have to understand which make Crohn's disease different from ulcerative colitis. Now, if you look at this graph, it shows you that what was the location at diagnosis 5 years later, 10 years later. And what we find is the location remained the same. People who had ileal disease to start with, 10 years later, still the same proportion of people had ileal disease. People who had ileocolonic disease, roughly the same proportion of patients had ileocolonic disease. Generally, there was no progression in the location, whereas in ulcerative colitis, there is often an increase in the disease location in terms of changing over from progressing from proctitis to left colitis to pancolitis, or maybe a reverse. However, when we look at behavior, we find there's a distinct difference. Patients who had an inflammatory disease at presentation, looked at them 10 years later. The inflammatory disease proportion had significantly gone down. What do you have out here? You have more of penetrating disease. The penetrating disease, which was left less earlier, significantly increases over a period of 5 to 10 years. In other words, there's a progression in behavior, 20 to 30% over 5 years. So what it tells you that if you're going to look at progression of behavior, what is more important is imaging. So imaging is going to play a very significant role if you're going to manage Crohn's disease. So better make radiologist as one of your friends, because you look, behavior keeps on changing, and the only way to map behavior is if you look at the images. Essential investigation. So if you are going to give an identification tag to the patient, there are certain investigations which every patient should have. We often see that a patient has colonic disease. So initially the doctor feels, the treating physician feels there's no need to look at small intestine. Let's treat the colonic disease and we'll see later. No. An identification tag has to have all the elements. So do a hemoglobin, the baseline investigation of which albumin is very important. You'd like to monitor it. ESR, CRP are important. Viral markers, because you're going to put these patients on immunosuppressants subsequently. Ileocolonoscopy and biopsy, but don't stop out there. Patient has small intestinal symptoms or no small intestinal symptoms, you would like to do a cross-sectional imaging, and that has to be in the form of either CT enterography or a MR enterography. That would depend. Generally, MR is preferred because the risk of radiation is much less, and such patients require, it's a chronic relentless disease, such patients require repeated evaluations. If perianal fistula is there, then you may do a MR pelvis. Now, on the left-hand side is what is known as a CT enterography, where you give negative or neutral contrast. And on the right-hand side is a regular normal CECT abdomen. And why I put up this slide is that still at times, we often confuse and think that CECT abdomen should give us good enough information when it comes to identifying, treating, managing Crohn's disease. No. Even though it is, for the patient, it may be a little bit more troublesome to do CT enterography, but the amount of information which CT enterography or MR enterography gives is much superior as compared to CECT abdomen. And in fact, if you look at both the pictures, this picture should be enough to satisfy that argument in terms that you're really going to miss lesions if you're only going to do a CT abdomen or an MRI without enterography. So we have looked at location, we have looked at behavior. Now we would like to know the activity of the disease, and that is a true gray zone. The activity index which is used is Crohn's disease activity index, which is based on 8 variables, which have weight variables. And here you need to recall symptoms over a period of 7 days. In other words, it's a full mathematical formula. So right now it's good that apps are available on your mobile, so you can calculate the Crohn's disease activity index and all. But it is a very tedious thing. And moreover, it is predominantly used for patients who have an inflammatory disease. So it is not actually very useful. In fact, in clinical practice, so CDI is something which people use more for research trials, research setting. In a normal OPD setting, you may use Harvey-Bradshaw index, which is much simpler to use, looking at general well-being, abdominal pain, number of liquid stools, abdominal mass, and complications, etc. But remember that when it comes to activity, the activity indices are the least well developed in Crohn's disease, considering the amount of advancement which has occurred. And these activity indexes are complex, difficult to use, and actually do not correlate well with endoscopic and radiological severity. So you should remember the limitation for these indices. So coming back to the checklist, we have defined the disease. We have looked at location, behavior, duration, activity. Now comes the second important point, to stratify the patient. And this, to my mind, is an extremely important slide. This slide, I would say, represents around 10 to 15 years of work of at least 50 to 100 papers from different books. Because if you need to treat the disease effectively, if you want to get one step up before the disease, if you want to preempt the disease and its complications, you need to be very sure that whether the patient you're dealing with is going to have a progressive disease or a non-progressive disease. Does he have an aggressive disease or a non-aggressive disease? Does he have a high risk for progression or does he have a low risk for progression? Many factors have been described. I've just put on out the 4 or 5 factors which I feel are extremely important, and they are something which in a snapshot, the moment the patient walks into OPD, you can decide. You can immediately put it in your mind. He is a high risk, low risk. And these factors are often younger age, but younger age alone is not significant. But along with that, if you have a fistulizing disease, perianal fistula, if you have early stricturing disease or a penetrating disease, extensive small bowel disease, that is small bowel involvement more than 100 centimeters, upper GI disease, a rectal involvement with deep ulcers because a high risk of going on to fistulizing perianal fistulae out there. So these are 4 or 5 factors which should come to your mind, and they should help you in deciding, in stratifying. Is it there's high risk of progression or low risk? And these are points which should be entered in your OPD file. And this has got nothing to do with any research setting. This is when you're managing patients. So once you have done that, we come to selecting appropriate therapy. Now, I put a table out here in terms of the regular treatment which is used. When we say regular treatment, that's a step-up approach. What do we mean by step-up approach? That is escalating the treatment according to the disease activity. So if we go through this table, we find there are 2 principles. One is induction of disease, induction of the remission, I mean to say. Second is maintenance of remission. So there are first-line therapies, and then there are second-line therapies. If you look at first-line therapies, for L1 or IL disease, 5-ASA is good for induction for mild disease. I put a star out here. That star shows it is not evidence-based. I'll discuss it later, but yes, it is used. Budesonide for induction of moderate to severe disease. For maintenance, azathioprine is the best drug. And second line is biological. Whenever steroids don't work, azathioprine does not work. So if it is a colonic disease, then you would like to use sulfasalazine or 5-ASA. Induction, if it's a moderate to severe disease, prednisolone, and maintenance remains azathioprine. Second line remains Biologics. If it is an ileocolonic disease, again the same. If it is an upper GI disease, then you may have to add proton pump inhibitors in addition. Now the problem out here is that how are you going to optimize the dose? And second issue is that while we have talked about right now is stepping up therapy, escalating therapy. There's another concept which is known as top-down therapy, that is intense therapy. So in step-up therapy, we go on from sulfasalazine, prednisolone, azathioprine to biologic agents. Top-down therapy, there are certain situations, instances where we feel you may straight away start with biologic agents. You may straight away start with biological agents plus immunomodulators. And if the patient does not respond, then you may go on to steroids and all, because then you do not have an option. When do you apply this strategy? It is very clear that if we have a low risk of progression, elderly patients, inflammatory phenotype, just a colonic disease without any rectal deep ulcers, non-structuring disease, non-penetrating disease, you go for step-up therapy. However, if you have decided that this patient has an aggressive disease, and that was based on the factors which we discussed, that is younger age less than 40 years, complex perianal fistula, early structuring disease, extensive small bowel disease, or upper GI disease, then you may go for top-down therapy. So this is true for every kind of Crohn's disease, whether it is luminal, whether it is penetrating, whether it is fistulizing or structuring. Finally, this is a relentless disease. There are going to be flares. So whenever a patient comes to you with flares, there are 4 points which should immediately come to your mind. You should check through these 4 points before proceeding further. First is smoking leads to aggressive disease. Although Indian data does not totally corroborate with that, but that is only one study. NSAIDs definitely lead to relapse of the disease. Secondly, if the patient has a flare, you would like to check for adherence. These are chronic illnesses. Most of the times, patients are not even themselves sure whether they're taking all the drugs properly or not. Then you would like to know whether they still have the flare is because of an active disease, or is it because of some other disease which has intervened. It is because of some complication. The complication may be something like malignancy, or some other disease may be another infection which could have set in. When you have ruled out these 3 points, then you would like to see the medicines which you're going, whether you have optimized their dose or not. Are you giving the medicines in the proper dose, or are you underdosing them, or you need to add something? So these are the 4 golden rules. And to my mind, this remains one of the most important slides, because this is a platform. This is what you would call the Google map for treating any kind of Crohn's disease. For every patient, you should define the disease, stratify right at onset, it is going to be aggressive or not, because your antennae are going to be up the moment you know it's a high-risk disease. Every time he comes in, and these patients are going to come to you time and again, you're going to decide, okay, this is a high-risk disease, I have to be very careful. I have to be aggressive also in terms of changing my treatment. Select the appropriate therapy according to the stratification, and rules for managing flares are going to be applied in every patient. And if you apply these rules, you're not going to make any mistake, or you're going to make the least amount of mistakes. So keeping this checklist in mind, now let us start applying it on patients. We have, let us say, a patient who is inflammatory phenotype, B1 phenotype. So as we discussed, inflammatory phenotype often tells us there's a low risk for progression. So if there's a low risk for progression, you would like to go for step-up therapy or escalated therapy. So if it is going to be escalated therapy, you would like to give either 5-ASA if it is ileal, and if it is colonic, sulfasalazine or 5-ASA, or otherwise give budesonide or prednisolone and subsequently azathioprine, and thereafter biological therapy if the patient does not respond. What does the data say? Data, however, tells us that when it comes to 5-ASAs, only sulfasalazine has been found to be superior to placebo, and that only for induction. For remission maintenance, induction, mesalamine and sulfasalazine, they have been found to have no role. But yet, in real life, what has been seen that many patients of mild Crohn's disease with inflammatory phenotype, if they have started on 5-ASA, they seem to be doing well, and we do not see any reason why it should be stopped in such patients. And if they have a preference, they should be continued on 5-ASAs as long as the risk of progression is low. That is what you keep on evaluating. The second thing when you give 5-ASA is optimize. What is the optimization for 5-ASA in Crohn's disease? The mistake often made is that the drug delivery site is very important for different kinds of 5-ASAs, and so one should be careful about that. If it is only a colonic disease, then sulfasalazine will work. Sulfasalazine will not work if it is an ileal or jejunal disease. If it is just a terminal ileal disease, then mesalamine pH-sensitive release tablets would work. If it is a jejunal disease, proximal ileum disease, then mesalamine delayed release capsules are going to work. So depending upon the site of involvement, you will have to tailor your 5-ASAs. For steroids, you can give budesonide, which has a very high first-pass metabolism, or you can give steroids, which have a low first-pass metabolism. So the benefit obviously is less of side effects, but at the same time, remember that budesonide will be released mainly in the distal ileum, terminal ileum, and perhaps proximal colon. So if the disease is limited out there, then it makes sense to give budesonide. Whereas steroids will be distributed everywhere. So if it is a predominantly colonic disease, then budesonide is not going to work. If it is colonic as well as small intestinal disease, budesonide is not going to work. So you have to remember that. Generally, you start in dose of 40 milligrams and 9 milligrams of budesonide and 40 milligrams of prednisolone. No point starting high doses, and taper off in 3-4 months. That's very important. Do not let them marinate in steroids for months and months. Azathioprine, there are 2 or 3 very important things. This is an important diagram because it helps in management. Azathioprine gets converted to 6-MP, then it gets converted into 6-TG. 6-TG is an important metabolite by which, because of apoptosis, the mechanism of azathioprine is termed in terms of immunomodulation. So what is important out here is TPMT enzyme, because this is a bypass pathway for azathioprine and 6-MP. So if TPMT enzyme is very active, you'll have low 6-TG. Low 6-TG means less of action. However, there's another player which has recently come up, and that is NUDT50. What has been seen is that TPMT polymorphisms are more common in Caucasians, whereas in Asians and Indians, it is the NUDT15 which plays a very important role. So azathioprine, how would you start? You would start with the dose is 2 to 2.5 milligram per kg, 6-mercaptopurine is 1 to 1.5. However, the adverse events are in form of leukopenia, thrombocytopenia, or hepatotoxicity. So you have to have 2 kinds of approach. One is step-up approach, other is pharmacogenomic. This is one drug where pharmacogenomics has done wonders. Step-up is you start with low dose and just monitor with CBC, LFT, and check that what is happening, because if leukopenia or thrombocytopenia happens, then you can decrease the dose. Pharmacogenomic is for NUT15 polymorphisms. It is available in just very select places. If it is normal, then you go up to straight away start with the normal dose, and you can check. This way you can regulate the adverse events. Another issue is that if the thiopurines are not working, patient is not responding, you can also check for metabolites, which again are available in select places, but yet at the same time, knowledge of it helps. One is that if the 2 metabolites, as we go back to the diagram, which are important, are 6-TG and 6-MMP. So if you look at the ratio of 6-TG and 6-MMP, it will tell you whether enough drug is reaching at this site, which is the site of action, or not. So if 6-TG is low, 6-MMP is low, the patient probably does not have taking the correct dose. You need to assess the compliance. If the 6 Tg is very high, that means despite enough drug reaching out there, it is not acting. Change to another drug. If it is low 6 Tg, high 6 mmP, then you know it is a shunter. That means you need to inhibit xanthine oxidase, which you do by allopurinol, and that might help in mild. There are 5 or 6 issues with azathioprine. I put them in one table. These are very practical issues. So when do you say no response? Minimum 3 months of therapy, because azathioprine takes that much time to be fully effective. How do you optimize therapy if the patient is not responding? Increase the dose up to 2 to 2.5 milligram per kg. Or even if you do not have metabolite levels, you can add allopurinol 100 milligram and decrease the dose of azathioprine to 25 to 50 milligram. How long can you give azathioprine? 4 to 7 years, even beyond that. What is the issue with long-term azathioprine? Risk of lymphoma in 1 to 10,000. What is the second-line drug if azathioprine is not effective? It is effective in just 60% of cases, but that's a good number, but still 60%. Then in Crohn's disease, methotrexate also seems to be effective. So you can start methotrexate, subcutaneous, 25 milligrams for 3 months, and thereafter give 15 milligrams thereafter. Now let's come to the second group of patients. These are the tougher patients. These are the patients which will give you a headache in terms of you come back again and again and you really do not know how to help them out unless and until your principles and fundamentals are very clear. So let's again apply the checklist to this second group of patients, and they comprise 30% of patients, I would say, in your OPD or hospital setting for amongst the Crohn's disease patients. That is B2 or the structuring disease. Is it high risk or low risk? It is high risk for progression. So would you like to go for top-down therapy or step up? Yes, top-down therapy. Unless until the patient cannot afford, then in those cases, you have no choice but to start with step-up therapy, that is steroids. Most important thing, you need the help of a radiologist, a surgeon, a pathologist out there. You have to have multidisciplinary care if you really need to treat these patients very well. The second important concept, in B1 disease, we were dealing only with inflammation. Now two things have added on. One, whenever there is inflammation, there would be fibrosis. Because once there's inflammation, there's healing, there would be fibrosis. So inflammation and fibrosis would go hand in. And because of that, if it is a small intestine involvement, essentially, there will be malabsorption and malnutrition. So remember these problems when you are treating this group of patients. If you remember these problems, you will be able to treat them well. So B2 structuring disease comes to you. What do you have to first do? Whether the patient has stricture, it is predominantly inflammatory or predominantly fibrotic. If the patient is in complete obstruction, then obviously the patient goes to the emergency services and all. Otherwise, these patients generally come with recurrent episodes of partial recurrent obstruction. So if it is going to be inflammatory or fibrotic, a CT scan will help you, a CT enterography. A CT enterography will show you thickening of the wall, ural stratification. If it is inflammatory, Crohn sign. If it is fibrotic, it will show you homogeneous enhancement. This is a stricture, right? But is CT the best? No, better than that is MR enterography. And MR enterography, there are two protocols. One is diffusion weight MR. Diffusion weight MR is a normal protocol whenever you do MR enterography. And here what you see is that if you attach it to the corresponding apparent diffusion coefficient, and if you find that the apparent diffusion coefficient is low, then that means that there is going to be inflammation here. There is another technique which is not available in many centers in India. That is again MR based. That is axial magnetization transfer. But at this moment, diffusion weight MRI does help in majority of the cases, although not in 100% of cases. So you would like to do a CT or MR, preferably a MR diffusion weight, which will tell you it's an inflammatory or fibrotic stricture. If it's an inflammatory stricture, as I told you, you would like to go for top-down therapy. However, step-up can also be done. You have a choice. And if patient is unaffordable, obviously go for step-up therapy. If top-down, now we come to biologics. If it is a fibrotic stricture, then you have choices of endoscopic therapy, resection, surgery, spectroplasty, surgery. Correction of nutritional status is very important. As I told you, inflammation, fibrosis, malabsorption. So you have to keep the whole picture in mind. Biologics. So, sir, do you want me to stop out here or should I continue? Finish biologics for 5 minutes and then take a break.
I think maybe you could take some questions. What do you think, Dr. Matthew, if you can unmute yourself and get some questions out of the way now?
Yeah, I think we can, because there are so many questions, and
60 already.
Yeah, some questions is regarding the 5 ASA. Dr. Sandeep from Jaipur he asked about the real role of 5-ASA in IBD. There is another question from Dr. Ishu from Bhopal. Its general recommendation is that there is no role of 5-ASA in Crohn's disease.
So I think I'll clarify it out here. It's very clear that when it comes to guidelines, 5-ASA do not have any role because that was based on systematic review and meta-analysis. However, when we look at real-life data, it is very clear. A lot of patients, not only in Western countries like Europe and USA, Europe where echo guidelines have been made, but also in Asian countries, patients particularly with endoluminal Crohn's disease, mild disease, who have been started on 5-ASA and are doing well. So 5-ASA does have a role, although when it comes to strict evidence, then the evidence or the guidelines do not support it. Yes, we are very clear that guidelines do not support it, but yes, at the same time, world over, people know that there is a group of Crohn's disease patients which do well with 5-ASA.
Yes, it is true. But Vineet, where is it acting? Is it only in Crohn's disease involving the colon, or it is distal ileum, or any part of GI?
So I showed a slide out here. Mesalamine delayed release would be effective in jejunum, ileum, colon. Mesalamine pH sensitive release would be effective in ileum, distal ileum, and colon. Colon, you'll have like sulfasalazine that would be effective. So you pick up your choice. You optimize your 5-ASA according to where they're going to get delivered.
Okay, thank you. Another question from by Dr. Gunjan Joshi from Rajkot. And isolated jejunal disease, only an ulcerative lesion in the jejunum. So how will you classify this lesion?
So isolated jejunal disease, you'll classify it as L4 disease. Location L4, and if it is stricturing, then B2. If it is non-stricturing, as B1.
In your imaging, another question has come from Dr. Chandrakant from AAG. Instead of enterography, you think enteroclysis will be more beneficial?
Enteroclysis is putting in a tube. So if you have a lesion which is very proximal, just like after DJ junction, just proximal jejunum, there is one subset where you may do enteroclysis. Otherwise, no. Enterography is much more convenient for the patient, much more easier to do, and provides very good information. It's only if it is very much upper jejunum. That is very few patients. There, at times, you may do enteroclysis.
Thank you. Another question is by Dr. Harish Tarak from Mumbai. Suppose a patient has only a perianal fistula and other markers are negative for any activity, and it is presumed to be Crohn's disease. Then how will you manage that patient? Only isolate.
When it comes to perianal disease, then I'll answer that question.
Okay then. Then what is the current role of TPMD in India? Do you recommend?
TPMT not recommended. If you really want to be very sure, then you can do TPMT. Otherwise, first go for NUDT15. NUDT15 will take care of 95% of your cases. Or
is it available in India? NUDT15?
Select centers. Very select, 2-3 places.
Another question is by Dr. Shreya and from Lucknow. Isolated ileal disease. Started on budesonide. The patient is not responding. Should we start on systemic steroids?
Yes, that's the step-up approach. If patient does not respond to budesonide, go to steroids, oral steroids. If the patient does not respond to oral steroid, then you go to biologics.
Similar questions.
If the patient does not go to biologics, before that, I'll show you a slide subsequently. Surgery is a very good option for terminal ileal non-obstructive disease. I'll show you. Towards the end, if I get time, I'll show you that slide.
Dr. Matthew, I think 5 minutes is what you wanted. So probably if you have one last question, fine. Otherwise, I think we can move on with the talk.
Another question is by Dr. Ankur Jain from Udaipur. There's a single ulcer in the ileum and no other finding on imaging and capsule endoscopy, etc. So how do you manage this patient?
So I think this is a question we can take up in absolute end, terminal ileitis. So let me complete the rest of the thing, and then we can start with this question only in the end.
Okay. Thank you. I think you can proceed.
Okay. So now Biologics. Biologics, let us be clear that monoclonal antibodies, first is that you have macrophages. Macrophages release TNF-alpha. TNF-alpha antagonists we all know, infliximab, adalimumab, golimumab, and all. Then subsequently it was seen that lymphocytes, they need to cross the endothelium so as to reach to the site of inflammation. So they have to cross the endothelium. They have to attach to receptors on the endothelial wall. So they have the T cells have receptors on themselves, which are known as alpha-4 beta-7, and they attach to MADCAM receptors on the wall, and if they attach to them, they roll through the endothelium, go to the site of inflammation. So if you block alpha-4 beta-7 by vedolizumab, then as a result, you can block the lymphocytes from reaching the site of inflammation. So these are known as lymphocyte trafficking inhibitors. And you have second generation of lymphocyte trafficking inhibitors, where if you block B7, which also gets attached to the epithelial cell, that is known as ectrolisib. You have another class of drugs which is coming up, and it has already got the FDA approval. That is, if you have IL-12 or 23, they have a common subunit which is known as P40. So if you have an antibody to this, then you are blocking Th1 pathway as well as Th17 pathway, and that is ustekinumab or Stelara, very popular, becoming a very popular drug. And you have IL-23 or P19 antagonists also. So these are broadly the biologics which are there. When it comes to biologics, what are the 5 questions which come to your mind? How to start biologics? What is the combination therapy related to biologics? When to stop biologics? What is the sequencing of biologics? And when a patient does not respond or stops responding, then what is the next step? Indications. Very clear. Steroid dependence, steroid refractory. What is the definition of steroid dependence and refractory in Crohn's disease? Steroid dependence is if tapering of steroids within 16 weeks is impossible, or after stopping, within 3 months, you have steroids recurrence. Steroid refractory is active disease, despite taking corticosteroids for 4 weeks. So you have any disease which is not responding to steroids, or as we discussed, a top-down approach, fistulizing disease, post-operative recurrence of disease. These are all indications of biologics. Sequencing of biologics. This is again a very, very interesting slide, and I would like all of you to go over it carefully because all these agents are also coming up. So let us look at what is the data. If we have a B1 inflammatory disease, we find that infliximab, adalimumab, TNF inhibitors, vedolizumab, lymphocyte trafficking inhibitor, ustekinumab, which is IL-12, IL-23 inhibitor, they're all effective. Yet there's a caveat out here. If it is a B1 severe disease requiring immediate action, then vedolizumab probably would not be the drug to be used out here. It is not effective because vedolizumab is only gut selective and it has a slower onset of action. Remember that. B2 structuring disease, the data is available only for infliximab and adalimumab and not for Vido and ustekinumab. So you would not like to use them in this setting. Extraintestinal manifestation, if a patient has, again, the data is not available for Vido and ustekinumab. You only have data for inflixi and adalimumab. Pregnancy, again, most data is available for inflixi and adalimumab. Infection and TB, yes, the risk of infection is least with vedolizumab, and particularly TB seems to be the least. So there that appears to be the first-line drug. But then remember that it is not effective in a severe disease, which is inflammatory, and certainly structuring disease or extraintestinal manifestations, we do not have any data. So this chart will clearly tell you when you have to start biologic in any setting. How do you start? We'll talk about fistulizing disease later. When you're going to start biologics, since it's the time of Corona, which has made us wiser, we always talked about this, but now I think it has become imperative. That is, we vaccinate them. And if you're going to vaccinate them, then remember that live vaccines require a minimum of 4 to 6 time period of gap before you start immunosuppressive therapy in the term of high dose steroids or in terms of biologics. Whereas skilled vaccines may be given, although their efficacy may be less. Then you have to screen for TB. If you're going to screen for TB, do a Montus test, do a CCT test, do a IGRA test. You may do both Montus and IGRA if possible, otherwise do one of them. And if any one of them is positive, it shows active TB, obviously you won't start. But if it shows latent TB, that is Montus positive or IGRA positive, then you would like to give treatment regimes in form of simultaneously before starting biologics, that is INH 9 months or INH plus rifampicin 3 months, or you can also use rifampicin 4 months. You can use any of these regimes which can be used. Now the question comes when the biologics you have initiated, they do not work. You have induced remission, you are maintaining remission for them, patient comes back with symptoms. If a patient comes back with symptoms, remember one thing, that either there's a loss of response, but before you decide loss of response, are the symptoms, go back to that checklist which I gave you. 4 golden rules for flare. So one of the golden rules of flare was smoking, adherence. Adherence will not be a problem out here. Here the question is there a superimposed disease? Superimposed disease out here could be TB, could be malignancy. TB because 10% of patients with anti-TNF inhibitors go on to develop tuberculosis. That also in first 3 to 6 months, so you have to be very careful. Loss of response may be related to low serum albumin levels. Otherwise, you can do a therapeutic drug monitoring. And therapeutic drug monitoring, I'll talk about in the next year. So patients, if they are doing well while on biologics, do not do any therapeutic drug monitoring. You do not really need to spend patient's money on that. If a patient while on biological therapy has active IBD, measure anti-TNF drug levels, trough levels, which are generally, it should be more than 5 for infliximab, more than 7.5 for adalimumab. If the trough levels are high, still the patient has active IBD, then you know it's a mechanistic failure. You have to stop these TNF-alpha drugs and switch over to another drugs, which other biologics are not available in India. If they were available, you would have started with vedolizumab or ustekinumab. Otherwise, you go for surgery or steroids. If there are no, the trough levels are less, and then to decrease the immunogenicity, you would also like to give combination therapy whenever you're giving biologics. But remember, that is true mainly for infliximab. You may give azathioprine or methotrexate for 6 months to 1 year. That may decrease the immunogenicity. Gradually, data has come up that with the adalimumab, even by adding azathioprine, the immunogenicity does not decrease or something like that. So it does not really help. With Vido and ustekinumab, the immunogenicity, as it is, the responses are low, so it is not required. So when biologics do not work or they are not affordable, you have alternative agents which are available. This is particularly true for resource-starved countries, and that is like tacrolimus, MMF, thalidomide, or you may give exclusive enteral nutrition, or you may go for surgical resection. Finally, the question is that can you stop biologics? Yes, you can stop biologics after 1 to 2 years if you find that the patient is in clinical and mucosal remission. However, continue azathioprine and methotrexate. Remember that even if you stop them when the patients are in remission, they would be relapse. Half of them would relapse at 1 to 2 years. And even when they relapse, if you retreat with biologics, it is safe. But patients who have a perennial disease or complicated disease, there the chances of relapse are much higher. So you can de-escalate or exit when it comes to biologics. So coming back to this patient who had a B2 disease, structuring disease, and predominantly inflammatory, that is where we went down this line. If the patient had a fibrotic stricture, then stricture is accessible endoscopically, then you would like to go today for endoscopic dilatation. When do you go for endoscopic balloon dilatation? If the stricture is short stricture, less than 4 centimeter in. If they are 1, 2, 3 strictures, maximum 3 strictures in close proximity. If it is a long stricture, multiple strictures, stricture with a lot of inflammation, deep ulcers, pre-stenotic luminal dilatation, concurrent fistula, they are not good for endoscopic balloon dilatation. You should not attempt them. And when you do endoscopic balloon dilatation, there are 2 approaches, retrograde approach and antegrade. Retrograde is that if possible, if the scope is passable through the stricture, then you cross the stricture and then dilate with the pulling back the balloon, which does not occur in majority of cases. So majority of cases, you end up doing antegrade balloon dilatation also. If the patient is not available to balloon dilatation, you have 2 surgical choices. One is stricturoplasty, which is more operative for non-inflammatory small wall strictures, not for colonic strictures, not for inflammatory strictures. For inflammatory strictures or colonic small bowel inflammatory strictures, then resection and anastomosis has to be done. Stricturoplasty will not work out. But whenever a patient is operated upon, surgery is not curative. Crohn's is going to come back. The recurrence is going to be clinically silent initially. It is going to be histological, endoscopic, radiological, then clinical. And by 3 to 5 years, 30 to 60% of patients are going to have recurrence. So how are you going to manage? To manage that, you have what is known as gold standard is do a ileocolonoscopy. If you can go to the anastomotic site, do you look at neoterminal ileum? And there's a Rutgers score for that, which tells you what is the risk for clinical recurrence. Like a less number of ulcers, the risk of recurrence is low. If there are more number of ulcers, diffuse inflammation, the risk of recurrence is very high. So if a patient has undergone resection, do not leave the patient. Ask the surgeon to send the patient back to you. What do? Give antibiotics for first 3 months. You may do a ileocolonoscopy at 3 to 6 months. And if the patient has, if you find according to Rutgers, if the patient has high risk, go for azathioprine or TNF-alpha inhibitors, that is biological monoclonal antibodies. If the patient is Rutgers 0 or 1, low risk, then in that case, you may continue with 5 years and intermittently give azathioprine. Repeat ileocolonoscopy at 18 months again. Fistulizing disease, very difficult, but again, they form 5 to 10% of cases. In fact, if you add perianal, they form 20% of cases. Ileoanal fistulas, enterocutaneous fistulas, ileovesical fistulas. Let's go back to checklist. What did our checklist tell us? Fistulizing disease, high risk for progression. You have to go for top-down therapy. You have to go for multidisciplinary care. The radiologist, the pathologist, the surgeon, very important. We talked in B2 disease that the patient not only has inflammation, he has fibrosis and malabsorption. In B3 disease, add another candidate to it, and that is infection. Very important because you have to get this concept right, because if you do not treat infection and only go for inflammation fibrosis, you're going to end up with problems. So what is the goal out here? Goal is intestinal preservation. First is treat the infection, control infection with IV antibiotics, improve nutrition. You have malabsorption, so you have to improve nutrition. Subsequently, go for percutaneous abscess drainage. Why percutaneous? Because you want to convert an urgent surgery to elective surgery. You want to preserve intestine. You have to have limited intestinal resection. The patient would have recurrent surgeries. Or if in case there is no abscess, you go for top-down medical therapy, and if it fails, then elective surgery. This is one setting again. If biologics do not work, it has been seen that exclusive enteral nutrition really does wonders. It can be given as exclusive or partial. It works as it's effective in approximately 2/3 of such patients. It's a very good bridge for surgery. Both oligomeric formulas as well as polymeric formulas, they provide similar benefit. Perianal fistula. Coming back to our checklist, applying it to perianal fistula. High risk for progression, yes. We talked about fistulizing disease having high risk for progression. So again, top-down therapy, again, multidisciplinary care. What are the additional issues out here? Here, first of all, divided into simple or complex fistula. There are special issues with biologics out here. Surgical therapies, there are some different surgical therapies and some neotherapies. So what is simple and complex fistula? How do you decide that? What investigation would you like to do? Best is to do an MRI, or you can do EUS. Sometimes some people also do examination and anesthesia. However, MRI and EUS is something which most people are comfortable. And that can help you in deciding if it is a simple fistula or a complex fistula. Simple fistula is single opening, low origin, no abscess along with that. Complex is above the puborectalis, multiple openings, or it may have perianal abscess, it may have rectovaginal fistula. So if it is a simple fistula, just antibiotics, ceton thread, fistulotomy should help. If it does not help, then you need to go for top-down therapy. Whereas in complex fistula, it is very important that these things are not going to help. You need adjunct measures like ceton and antibiotics, take care of infection, and then just go in for anti-TNF therapy, which is induction as well as maintenance. If the patient does not respond, then you may go for evaluate and go for diverting stoma. Like these are adjuncts when it's a complex fistula before any kind of therapy. If you ignore these adjuncts, your therapy would not be successful. That is, look for a perianal abscess, drain it. Put a ceton out there, put a cutting as or a non-draining ceton. Depending upon the location, it can be put in, and that will help in taking care of the infection. And thereafter, you go for biologics. Now, I have put the same table out there, which I showed you, except that I have put in two additions out here. B3 fistulizing as well as perianal fistula. What do you find out here? In Flixi Adali, we still have data. We do not have data for Vido and Stecchini. So if you look at this and post-operative recurrence, again the same thing. Vido and Stecchini, no data. Whereas minimal data, I would say. So if you look at this chart very carefully, what we find is that Inflixia Dali seem to be effective in most groups of patients. Every group of patient of Crohn's disease we deal with, including pregnancy, post-operative recurrence, and extraintestinal manifestations. Vedolizumab would be effective in B1 inflammatory, but again, not very severe disease where you want an immediate response, and or in elderly or in patients where the risk of infection is very high. There, if they have a luminal disease, vedolizumab can be the first line of therapy. Ustekinumab, again, is effective till now. Data is available only for inflammatory disease, not for stricturizing, fistulizing, or extraintestinal manifestations. In perianal fistula, the biologics take long time to act. The quantum of inflammation is much more, 12 to 14 weeks. So higher trough levels are required. The relapse risks are higher when you stop them. So, and if you do a fecal diversion, often people feel that that would work wonders. It works wonders for a few months. The response is there in 2/3 only. The disease is such that it is relentless. It keeps on coming back. So the restoration of continuity once you've done a fecal diversion is there in only 10 to 20% or 30%. So you have to be very careful. You have to be aware when you do a fecal diversion. It's only a temporizing measure again. Remember, there's a risk of malignancy in perianal fistulizing disease. Other refractory cases, you can go for video-assisted anal fistula therapy. You can go for mesenchymal stem cell injection. These are available in 1 or 2 centers in India. At AIMS, both these facilities are now available. Now I'll talk a few, for just 5 minutes would be to end it up with the game changers. We have discussed till now checklist. We have talked how we can approach a B1 disease, B2 disease, B3 disease, and perianal fistulizing disease. What are the game changers which have come up over the last 2-3 years? Which are, first is surgery as an alternative to biologics. The question was raised that if there's a terminal ileal disease which is non-stricturing, patient has been given steroids, or even if it is stricturing, patient has been given steroids, patient is not responding. Would you go over to biologics? I would say that there's a trial which came up from Netherlands which clearly showed that if it is a limited disease and in less than 40 centimeters, laparoscopic ileal resection was as good as infliximab. In other words, it can be a very good alternative. So, and obviously for an Indian setting, it would be less expensive also. So you can clearly go for that. But remember, post-operative recurrence would be there. You have to manage that. Number two, the implication of mesentery. Right from the first report of Crohn's disease, we know CD involves more than the mucosa. There's ball wall thickening. Surgeons always talked about mesenteric fat creep. But now even the physicians are talking about it. It has been seen that mesenteric fat seems to be very important even in pathogenesis. And it is important because the trial from Ireland which came up, which clearly showed that surgeons, when they went for mesocolic resection and excision and extensive mesentery was removed, inclusion of mesentery led to reduced surgical recurrence. So this remains debatable, yes, but at the same time, you can plan with the surgeons when you send a case of Crohn's disease for surgery, you can at least talk to the surgeons whether removing more mesentery would help or not, although I would say it's a little bit difficult. Then we have a very good biomarker which has come up, and that is calprotectin. Calprotectin is a protein, cytosolic protein in neutrophils. So whenever there is inflammation, we talk about that neutrophils or lymphocytes or neutrophils particularly, they will go through the endothelium, there will be migration through the epithelium, and as a result, whenever there is inflammation, the neutrophil lysis may occur, leading to release of this cytosolic protein that is known as calprotectin, and this calprotectin can be measured in the fecal samples. And obviously, this will correlate with the inflammation. Any cause of inflammation will lead to increased fecal calprotectin. So particularly in colonic disease, it is very important. It performs less well in small bowel disease. Remember that. It is more important for colonic disease. Here you may have diverse results. You may not be very sure. Here the accuracy is much more. It also identifies patient at high risk for post-operative recurrence. Then finally, there are certain goals of therapy which are changing. There are terms which have been thrown in. And I thought that it would be just 2 minutes I can spend on it, that what are these terms and what is their relevance to practical clinical medicine today for IBD patients. They are mucosal healing, deep remission, complete remission, early Crohn's disease, treat to target, tight controls, tight consensus. Let me tell you, all of them roughly mean the same thing with very few variations. So when we talk about mucosal healing, we are talking about clinical and endoscopic remission. This may also be considered by some people as deep remission, although some people consider deep remission as that if you had histological remission. So mucosal healing is clinical and endoscopic remission. You want to go a step higher, you can go clinical and endoscopic and histological remission. So that is becoming the goal, right? Second, it has been seen that early disease, we talked about low risk. What were the criteria for low risk? Inflammatory phenotype. The criteria for high risk was stricturing and fistulizing phenotype. We know Crohn's is progressive in a majority of the cases. So if there's a window of opportunity, when it is an inflammatory phenotype, that is early disease. And in those cases, if you can pick up those cases, grab those cases, and you go in for very tight control in terms of patient management monitoring, then it may be beneficial. That is the concept which is going around. And what is the definition of early Crohn's disease? Which has been diagnosed within 18 months of onset of symptoms with no complications, no previous treatment with any of the immunomodulator agents. So treat to target. What is the target? The target was initially improved symptoms 20, 30 years back, 40 years back, then clinical remission, steroid-free remission, then 5-7 years back mucosal healing, then include histological healing and change the course of disease. So this is how the targets are changing. So when you say treat the target, which target are you going to treat? Obviously right now the target which you're treating is more of mucosal healing, although some clinical trials have started also treating the target of mucosal plus histological healing. And that is where we have the STRIDE consensus, which is the selecting targets of inflammation. And if you're going to treat a patient with Crohn's disease, you're going to treat intestinal inflammation. So you're going to look at resolution of abdominal pain. You're going to look at outcome assessment every 3 months or every 6 to 12 months and after symptom resolution. And how you're going to look at it? You're going to not look at only symptoms. You're going to do endoscopy. If the lesion is at a place not accessible, then cross-sectional imaging. You will also include biomarkers like fecal calprotectin. So in other words, if you have a patient of Crohn's disease, you would do every 6 months FCP, fecal calprotectin, that is an endoscopy. Or early institution of biologics within 2 years, early institution of immunomodulators. So does this work? This is the whole concept right now. Does it work? Is our countries all over the world doing it? No. It is right now still part of, I would say, realms of research. It is right now not clear at the moment. So for a given patient, you may do, but not as a general strategy. Let us be very clear about it. treat to target is coming up. Maybe in 6 months' time, once we have CALM-2 trials coming up. CALM-1 is a trial which has been published. Another trial has been being published, that is REACT-2 and CALM-2. So when their results come up, maybe we'll have more data. Right now, let it be clear to everybody that it is unclear whether therapy should be escalated in patients who have residual activity on endoscopy but are in clinical remission. Newer agents, ustekinumab, we have talked about, P40 unit of IL-12 and IL-23. We have tofacitinib, which has come up, that is Janus kinase inhibitor. Then you have sphingosine 1-phosphate is a receptor, which is there in the lymphocyte, so a lymph node. So if you do not let the lymph node, that's a receptor which decides whether the lymphocytes are going to come out of the lymph nodes or not. So if you do not want the lymphocytes to come out of the lymphocytes, then you can modulate this with the help of ozanimod. These are the new drugs which are going to come up. Finally, in the times of COVID, is COVID going to change our management of Crohn's disease over the next 2-3 months? This is the latest data from the registry, 959 cases, IBD plus COVID all over the world. There are 3 cases from India which have been included in this registry. What do you find out here? Patients, whether they're on sulfasalazine, they had COVID. Patients on steroids had COVID. Patient on azathioprine had COVID. Patient on anti-TNF had COVID. Patients even on anti-integrins had COVID. Overall, what it tells us that regardless of therapy, patients have developed COVID, but the case fatality rate has been 3 to 4%. Maybe it has not been substantially more. So it tells us that patients with IBD are not much more prone to COVID, although we have to maintain all kinds of precautions, particularly patients who are on immunosuppressants. But yes, at the same time, you can give all kinds of therapy. It's only if you are going to give high-dose steroids, that is something one has to be very careful. If you are going to give that, you may give low-dose steroids, but otherwise it seems that every kind of therapy can be. So concluding, you have a checklist. Remember this. This may seem the most mundane slide, but if you know this checklist and you apply it on any patient who walks into your OPD, you'll be able to crack every problem and not make the least number of mistakes. Defining the disease, stratifying the disease. Select appropriate therapy according to stratification. Whenever a patient comes with flare, go for smoking, NSAIDs, adherence, infection, malignancy. If all of them negative, then optimize therapy, and optimization I've told you for individual agents, azathioprine as well as biologics. B1, remember it has a low risk for progression, so step-up therapy is fine. Inflammation is the main component of it. B2, remember it has a high risk for progression. So you may go for top-down therapy. You can also use step-up therapy, but multidisciplinary. Here, along with inflammation, you have fibrosis and you have malabsorption. Unless until you tackle all these 3, you will not treat the patient well. B3 fistulizing, again, high risk for progression, top-down therapy, multidisciplinary care. Here, inflammation, fibrosis, malabsorption, another very important component, infection. If you do not forget about infection, you will not treat the patient. Perianal fistula, high risk for progression. Top-down therapy, multidisciplinary care. Here, divide patient into simple, complex fistula. Special issue with biologics, in more time required, probably higher dose required. Go in for surgical therapy, ceton and antibiotics are very, very much required. And finally, we are moving towards what is known as the STRIDE consensus. The second part of it is known as the SPIRIT consensus. The SPIRIT consensus has still not gone into print. It should go into print very soon, within another 1 or 2 months. And there, everybody is talking about not only changing the goal from endoscopical cross-sectional imaging or biomarkers to quality of life, psychological well-being, fatigue. So maybe 6 months down the line, when we're talking about it, we'll have another slide out here that will be known as a SPIRIT consensus. Thank you very much for your patient care.
Well, outstanding talk, Vineet. You've covered the area extensively, provided a lot of messages and scenarios, and conveyed information, albeit at rather supersonic speed. So people have had really got to keep themselves glued to your lips and sound to understand what you've said. The number of questions has crossed 305 questions. So I think you can see how much interest your talk has stimulated. What I'll try to do in the next 10 minutes or so is to cover about 8 or 10 of the questions that I think that lots of people have been asking. To start with, the simple question is Dr. Vimal Saradeva from Rajkot, as well as Dr. Sukanto Das from Dhaka want to know differentiating between an inflammatory and a fibrotic stricture in Crohn's disease. How do you manage that, deciding whether steroids or you opt for surgery?
So if it is an inflammatory stricture, you go for steroids, or you can also go for biological agents. If it is a fibrotic stricture predominantly, So there will be components of both inflammation and fibrosis in a structure. So it is never pure inflammatory, pure fibrotic. But if it is predominantly fibrotic, you may go in for endoscopic balloon dilatation, or you may go in for structuroplasty.
So the question is, how do you make that differentiation? That how do you make this call whether it is inflammatory dominant or fibrosis
Yes,
dominant?
is to do a CT or a MRI. MRI is the best. MR angiography, diffusion weight image. If you do a diffusion weight image along with you look at ADC, that is a coefficient, you can easily pick up whether the patient has.
Right.
So the underlying diffusion weight MR, which is part of protocol for any MR. It's not any special protocol. It can be done anywhere.
A diffusion weighted imaging, you look at the apparent diffusion coefficient, which is the best way to differentiate inflammation from fibrosis currently available. All right. There's a whole set of questions. About 7 or 8 people wanted to know about terminal ileitis, which had been referred to earlier. Single ileal ulcer. Sanjeev Kar from Katak, Pallavi Garg from Delhi. Common scenario, you find a few superficial aphthous ulcers. Rinkesh Bansal has asked the same question. You find a few superficial or aphthous ulcers in the terminal ileum, you biopsy them, you get some non-specific inflammatory change. How do you approach and how do you treat and follow these patients?
Vineet, if you can stop sharing your slide, then we come to gallery view.
I'll stop sharing it.
Yeah. So right. So did you get that question regarding the terminal ileum and superficial ulcers?
I would answer it this way: that first is that whether it is picked up asymptomatic or symptomatic. When you say asymptomatic, you're doing a screening colonoscopy, your patient has very non-specific IBS kind of symptoms, you find some superficial ulcers. In that case, the chances of progression are low, chances of finding a pathology are low, both progression and pathology. So in such cases, it's best to treat the patients just symptomatically and call the patient after 1 year and do a repeat colonoscopy. If the patient is symptomatic in terms of when we say symptoms, we are talking of chronic diarrhea, we are talking of fever, we are talking of weight loss, or we are talking of anemia. If the patient has any of those kind of symptoms and you find superficial ulcers or deep ulcers, take a biopsy. If the biopsy is helpful, fine. Most of the time, biopsy is not helpful. Then in those cases, you would like to also do imaging, which has to be in the form of a CT or MR angiography, preferably CT angiography in this setting. And in situ angiography, again, if you find that it is localized to that, there is inflammation which is localized to that segment, ileocecal segment, the ulcers are deep or superficial, and the patient also has symptoms. The biopsy has ruled out lymphoma or cancer, lymphoma or malignancy. And this is a patient with chronic symptoms. It's not enteric fever, amoebic nephritis, and all those kind of things. History of NSAIDs is not there. NSAIDs can also cause this kind of problem. That is also not there. Then in such a setting, you go the route of tuberculosis or Crohn's, see whether the patient has more chances of tuberculosis or patient of Crohn's, and treat it. So the key points out here are asymptomatic, do not treat. Rule out history of NSA. Chronic symptoms with deep ulcer, CT angiography also showing some localized ileal involvement, then you need to definitely treat, and then you need to decide whether it is tuberculosis or Crohn's disease.
Right. Thank you. That's quite a nice roadmap to follow. Dr. Antariksh from Chandigarh as well as Dr. Ravi Shankar from Hyderabad want to know the duration for which you can continue azathioprine. You mentioned the risk of lymphoma and how long can it be used once you've achieved remission in Crohn's disease, and what are the medico-legal aspects? Is there any risk in continuing azathioprine beyond 7 years, especially if the patient is in remission, or are there any alternative medications you can use for these people to sustain remission?
So there is no definite answer for this. Till 4 to 7 years, you continue. After that, also you can continue, but then you need to have a discussion with the patient. If the patient is educated and can enter in the sense that he can understand everything, then you need to tell the patient that there's a risk of lymphoma 1 in 10,000. Skin cancers are not so common in India. Otherwise, there's a risk of skin malignancy also. So you need to decide that there is a small risk, but the benefit, since when you stop azathioprine, even after 7 years, it has been seen that within 1 or 2 years, 50% of the patients have a relapse. Patients who are following renal transplant, it has been seen they have been taking azathioprine for many, many years. So here it is an informed decision which has to be take place in consultation with the patient. And many of the patients they stop azathioprine, they have a relapse, then they come back and then they say they were doing very well with azathioprine, they would like to restart it, considering that the benefit outweighs the risk. That would be there. And there you may evaluate them regularly, telling them about these.
So beyond 7 years, even if you continue, there will be an onus of a monitoring for lymphoma. Yeah. And which part, lymphoma of the small bowel, or where does this lymphoma normally appear?
No, it can be any part. Any NHL. So you have to look at all the symptoms.
Right. I think there's a lot of confusion regarding 5-amino salicylic acids, mesalamine, because I think guidelines you're saying they are not recommended. On the other hand, we're talking about your slides are mentioning there were places where you talked about using the right kind of mesalamine. And so Dr. Kshitij from Rishikesh wanted a clarification on that, as did a few other people, about what are your advice regarding and the place of 5-amino salicylic acid preparations in various forms of Crohn's disease.
So let me give 3 examples. A patient has only colonic disease, right? Then mild colonic disease, abscess ulcers, few superficial ulcers, then you can give sulfasalazine or you can give any of the 5 ASs. Patient has terminal ileal and colonic disease, left colonic disease and terminal ileal disease. Then in that, or a right colonic disease and a terminal ileal disease, then in that case, you can give 5 AS, any of the 5 ASs, because they start getting released from the terminal ileal. Patient has a jejunal involvement, proximal ileal involvement. Then you'll have to give mesalamine delayed release capsules like Pentasa, where they start getting released from stomach onwards. So there they may be helpful. But again, this has to be all these patients have to be mild disease. They have to have an inflammatory phenotype. And if the patient does not respond, obviously you switch over the therapy. You need not continue with 5 ASA. You need not continue with 5 ASA plus azathioprine or 5 ASA plus 0. Then you stop 5 ASA and continue.
Right. So that was another set of questions, that once you start ASA and steroids, what should you do about aminosalicylates that you have addressed?
They need to be stopped.
Yeah. Okay. Regarding fistulizing Crohn's disease, there was a Dr. H.P. Yadav from Indore had a question. And there was another question also on the same thing from Bangladesh, where they said if a person has fistulizing disease that is not responding to infliximab or biological therapy, what should be done? And what is the role of antibiotics? Could antibiotics also be helpful in inducing remission in fistulizing disease?
So if the fistula is in the small bowel, if it is a B3 disease, if the fistula is in the small bowel, then I showed one slide that if biologics do not work, then it has been seen that exclusive enteral nutrition really works. Exclusive enteral nutrition or partial enteral nutrition can be given. It builds up the hemoglobin levels, it builds up the albumin levels, and it builds up the nutritional state of the patient. It also has an anti-inflammatory component, so that decreases the inflammation. Although you can give it for a limited period of time, 8 weeks, 12 weeks, because of the palatability, cost, and subsequently, but it acts as a bridge. It acts as a bridge in terms of improving the patient, decreasing inflammation, improving nutritional status, and patient can go in for surgery after. If it is perianal fistula, then you can go for ileostomy, but ileostomy is not a wonder therapy. We always think ileostomy is that is diversion ileostomy or colostomy. That is a wonder therapy. No, it is not a wonder therapy, because the patients have a relapse after 2 years, 3 years, or something like that. And if there are some of the young patients, it has been seen that you're not able to restore continuity ever. So here your choices are, as I showed you, video-assisted anal fistula therapy or mesenchymal stem cell therapy can be given. But what you can do is that, again, at such times, even if such therapies are not available, you've done a fistulizing disease. So if you independently attack all 3 of them, you would have a successful result. The problem occurs, people only attack inflammation, or they'll attack only infection, or they'll forget about the malabsorption, the nutrition part. They all 3 have to work in tandem. That is why I gave the concepts out there for fistulizing as compared to a B1 or inflammatory phenotype, where it's only inflammation.
Right. I think that's clarity. I think that makes people realize you have to tackle all components of the problem. Regarding the perianal fistulae, it is generally classified with penetrating disease, was the question. And can you have Crohn's disease responsible for fistulae in the absence of any significant activity in the rectum? If you have perianal fistulae and there is not much rectal activity, you should still think of Crohn's?
Yes, it occurs in 7 to 10% of cases where you may have only terminal ileal involvement and you may have fistulizing disease. Where this thing helps is that if you find no fistulae, you find rectal deep ulcers, then you know there's a chance that 1 or 2 years down the line, there's a chance is going to come back to me with fistula. So there you will not treat only with 5-AS or sulfasalazine. Even if you've started it, you will monitor the patient. Call him back every 3 months because you know that this patient has a high chance of progression. Once he develops fistula, he has crossed a line towards a more aggressive disease. So if I can decrease inflammation before that, that would really change the natural course of disease for this.
Right. I think there is a whole set of questions. I think at least 10 or 12 people who would ask that a major concern is regarding stopping therapy, whether it is biologicals or stopping 5-aminosalicylic acid, azathioprine, steroids. When can you stop? Can you stop? What should be the monitoring? How should you monitor the disease activity to make up your mind regarding stepping down or stopping therapy altogether in Crohn's disease? Is it?
So there are two principles or three principles when you want to stop. You can stop biological therapy very much, right? Now, the thing is that importantly, the patient should be in clinical remission and possible mucosal remission. Patient is doing well, you did a CT and CT also shows that the strictures are all more fibrosed. You can stop it after 1 or 2 years of therapy, but continue immunomodulator like azathioprine or methotrexate. Do not stop both of two. Number 3, 50% of these patients are going to come back to you with a relapse in 2 years, 3 years. When they come back to your relapse, you can again start biological therapy and most of them would respond. So what you can do is, if it's a patient of colonic disease, you can just monitor with fecal calprotectin and see when he has a relapse. When he has a relapse, then you can decide whether you want to give steroids or biologics, and accordingly, if you give biologics, the patient. So if a patient is in clinical endoscopic remission, stop, but continue azathioprine. But there are certain subsets where if you stop, the chances of relapse are higher. Those subsets are perianal fistulizing disease or very aggressive disease, multiple stricture fistula. There, even if you stop, within a few months, the patient is going to come.
Right. A couple of quick questions regarding investigations. You talked about NUDT 15. So the question was from Dr. Jalihal as well as from Dr. Ramalingam in Pondicherry. What is the cost of NUDT 15 testing, and how important is it to do this testing? Should we really strive hard to do it, or it is only desirable if possible?
It is right now, because of the cost and the availability, lack of availability, it is desirable. That is why in one slide, I gave you two approaches. One is pharmacogenomic approach. If you want to straight away start azathioprine and 2 to 2.5 milligrams per kg, do NUDT 15. If it is normal, you can start it and monitor the patient. However, if NUDT 15 is not possible, which is true for most of us, 99% of us, then in that case, you start at low dose, 50 milligram, or even if you're more scared, 25 milligram. Do a CBC LFT every 2 weeks. Gradually hike up the dose of azathioprine. Take it to 1 to 1.5 milligram kg. If the patient is not responding, go up to 2 to 2.5 milligram per kg. And that way, and you do your CBC every 3 months so as to check out whether this thing. That way, for most of the cases, I would say it's a very occasional case where just with 1 or 2 doses of azathioprine, you will find that the patient develops myelotoxicity or develops alopecia and all. Otherwise, most of the cases, if you have a good monitoring, this is a very low cost and very effective strategy. So till the time NUDT 15 is available, the strategy works.
Right.
Sir, can we ask if Matthew has some questions before,
Yes.
because time is passing by.
Okay.
We'll have to bind up.
The number of questions has crossed 400 now. It's one of the highest questions we have had in any session. 406, 408 questions are on board.
Dr. Matthew, please. Dr. Matthew, please.
There are so many questions, as he told us, and there is no time to ask any of these questions. But there was a very basic question from Dr. Ajay Shinde from Hyderabad. You have told about immunosuppressants and immunomodulators. What is the difference? Is there any real difference between these two terminologies?
So essentially, if you look at it, then when we talk about immunomodulators, there we are talking about that probably the immunosuppressive action quantum is a little less. So if you make the classification, then the true immunosuppressants would be biologics, steroids in full doses, whereas steroids less than 20 milligrams, azathioprine in 1 to 1.5 milligram per kg, 6 mercaptopurine, they would fall in immunomodulators, right? So that this distinction is also very important, because when you're going to vaccinate, if a person is on immunosuppressant, then you will never give live vaccine. Whereas a patient is on immunomodulator, low-dose steroids, azathioprine, methotrexate, you can still give live pills. So there, this question assumes a lot of importance.
Relevant, yeah.
And there is a question from Dr. Kamal from Guwahati. The patient has, the biopsy has grown non-MTB mycobacteria. Can I start the patient on biologicals?
Not at all. And unless until you have subsequently treated. If the patient has, because now this is the case of MAP, Mycobacterium avium paratuberculosis, or what we talk about Johne's disease, which occurs in cattle ruminants, or the human counterpart of that, MAP or non-tubercular mycobacteria. So there, obviously, the treatment would remain anti-tubercular therapy in a modified form. Clarithromycin has been found to be effective. Rifabutin has been found to be effective. So obviously, you would not start Biologics. If the patient is not responding, then go for surgery or non-immunosuppressive medication. Surgery would be the best in such a setting after you've given anti-tubercular therapy in modified forms.
There is a question about from yes, doctor, that is from Mumbai. For start biological therapy, and the patient had tuberculosis, and so patient is started on ATT. So how long to wait to start biological still be complete?
So if depends upon the condition of the patient. Ideally, you would like to wait for 4 to 8 weeks before you restart any kind of immunosuppressive therapy or biological therapy in this case. However, if the patient is, let us say, very sick, there you can decrease that gap to as you can like keep the gap for 2 weeks, 3 weeks, but ideally 4 to 8 weeks is the best. The ideal thing is do not start Biologics unless until you finish his ATT course. That is the best, right? 100%. Second is that patient is not doing well. You have to start Biologics. Then give a gap of 4 to 8 weeks. Third is patient is doing very badly. You have absolutely no alternatives. Then maybe within 2 to 3 weeks, depending upon what kind of tuberculosis it is, you can clearly make out whether there is some response coming or not. But that will be the third thing, would be something which has to be very, very, with a high note of caution, very carefully looked at. That is the third situation.
Matthew, can we stop here?
There are so many very, very, very interesting questions. So I think, as we can send him to by email so that he can answer. And then
but the chairperson, sir, I think you and me, two of us should sit down and answer the question. Both of us, sir.
Absolutely. Okay, and last question, is again just a short answer, please. Role of probiotics in Crohn's disease. This is by person called from Calicut.
That's a very interesting question, good question, and I was figuring that this question would crop up because I didn't talk about fecal microbial transplantation. When we talk about ulcerative colitis, we talk about microbial manipulation therapy. We always end up with FMT. So till now, the role of probiotics, microbial manipulation therapy can be antibiotics, probiotics, fecal microbial transplantation. Antibiotics have a very good role, as we have discussed. Probiotics, they do not seem to have any role as such. Fecal microbial transplantation, again, only case series, no randomized controlled trials as of. So that would be the status.
Wonderful. So simple summary is that probiotics, no role in patient with Crohn's disease. Right. So with this, Vanitha, it has been a masterly talk by you. I mean, all of us understand that the depth of knowledge you have on this subject is remarkable. God bless you for this. And for last 1 hour, it has been a great treat to listen to you on the concept of IBD.
And I think we need the reward you get for giving such an outstanding talk is, we have asked you 20 questions. You've got another 410 questions in your email that you have to answer. Okay. I think we'll all try to help, but the answers have to come from you.
So these questions are on your way. We'll send these questions by email and see that if you can respond to these questions and our benefit out of it. On this platform, there is no way we can clap for you, but again, you deserve a big round of applause from all of us, and we clap for you on behalf of all the viewers and participants of this. There have been a lot of people watching on the Facebook. They have sent many questions. So we are not asking these questions to you, but they are on your way. So before we go further, I have something to share with you is regarding the outcome of 1 second. Sorry, I will say the outcome of those
yes.
Those survey we sent to you. some time back. So if I can share my screen from here.
Yeah, we can see. Just go full screen. Yeah, your screen is on.
All right.
You can see your slides. Yes, now that's full screen. Please go ahead.
This is a survey which we did for last 3 weeks, and what it shows, we ask the question that you are a member of ISG. Majority said they are member, but some of them are not members, but they would like to become member of ISG. We asked about which sessions. There is a consistency. Most people have participated in most of the talks, and audio quality was judged to be excellent and very good. I think we need to work on this. That we believe that there have been some issues at audio quality because at least 20% people have said it was not so great. So again, video, we need to get probably more better on that, and we'll figure out with our technical team that how we can become a bit more better. Topics covered have been good and excellent, and certainly all the topic we covered was typical CMEs which happen in any conference, and we had wonderful speakers. We also asked question that what format do you like to have? It's about 40 minutes of speakers time and 20 minutes of question and answer session, or half an hour and half an hour. Most people say that this format we follow, 40-20, they feel is good to them. Second, we also asked, we wanted to know that we had an opportunity during lockdown period that we could do masterclass. But will this masterclass be of interest to people if you in the later half once we come out of the lockdown state? Because most of us will go to work in a full scale, but majority people said that yes, we should continue with these master classes, and that speaks that the value of all the speakers who spoke till now have been so wonderful. We also asked that how frequent, if you do continue master classes, how frequent they should be, and most people say this should be once a week or twice a week. So most people say once a week, so probably we'll form it once a week master classes, and later probably we decrease less frequent, maybe twice a month or once a month. Which day? Again, days wise, most people say that the weekdays, I mean, the Sunday is the best here, so we'll continue on that on Sunday, and time of Sunday would be again 12 to 1 in the daytime. We got lot many requests on different topics, and we are working on those, and we have selected few more topics for next set of webinars. And lastly, a lot of people gave great suggestions, and one of the suggestions was that to create a library that all these talks, which are really masterclass talks, if they could be seen later or revised later. So all the masterclass talks have been put on ISG website, which is isg.ors.in, and there's a upper part you find a ISG library or video library. So go there, and all the talks have been placed there, so we can watch at your time whenever you feel like. And they also will be available on Facebook for long time. The also important observation, which we believe that how do we put this into our masterclass to become interactive, because this is more of a didactic that speaker speaks and everybody listens. But how can we increase our more interaction between speakers and the participants? So if we can create a platform which provides a online voting or polling system, we'll explore that part and request our technical team that we can induct. We should bring our young faculty and as a moderator and speakers. And we know that in our country there are wonderful youngsters who are doing remarkable work in many institutions all around our country. Certainly we'll invite them on this platform. Many residents also asked that if you could do some kind of teaching program, some kind of bedsides or workshop. Again, we have planned and thought that we could do some, because the DNB exams are coming up, DM exams are coming up, bedsides are not being held because of hospitals are, there are not many patients in the hospitals. Therefore, we thought we could do virtual bedsides. We are thinking about it, and maybe we come back to you on Wednesday, on this our final decision, that we will continue some bedsides, which could be virtual bedsides. And we will also request all the exam going who are watching this to connect to us, and so that we can discuss with you the modalities, how to do it, so we can do that. And with this, we again thank you all for watching ISG masterclasses. Today we had almost 1,400 viewers from many countries, and I'm sure that everybody else would have enjoyed. I enjoyed very much this talk. I learned a lot. I'm sure other viewers would have be benefited. Thank you, Vineet, for a masterly talk again, and as usual, thank you, Dr. Matthew Philip, kindly agreeing to come up to moderate this session. Thank you, Dr. Saraswat, for again wonderful support always in ISG, and you have been so wonderful. Thank you very much, Yogita. Thank you very much, the technical team. And we know that I hear that our the relay has been really very good. So therefore, thank you, Dinesh. Thank you, Amol. Thank you, all people behind the scene. And thank you, Sun Pharma, for supporting this activity. Before we ask Matthew here to want to say something, let me invite you for the next talk, which is coming up on Wednesday this week at 5 to 6. That is May 13, where again very important topic, acute on chronic liver failure, and all of us know this is an extremely important topic, and we have a we have a speaker who is so well known to all of you. We have seen him for last so many weeks continuously, Dr. Vivek Saraswat. So he will speak to you on this acute on chronic liver failure this Wednesday, 5 to 6. Dr. Matthew, you want to say something?
I just want to thank ISG, especially the President and Secretary, for giving me this opportunity to moderate this session. And I learned a lot, and it was a wonderful lecture by Dr. Vineet, and I think he has touched up everything. And that is actually, it shows the number of participants and innumerable questions. I tell you, there are really wonderful questions, which really is so tough to answer. Only you can answer that. And I congratulate for being so having so much information in IBD. I think I had never seen a person having this much deep knowledge in IBD. So I really congratulate. I also try to pray to God to bless you further for having a good future in IBD. Thank you so much.
Okay. Great.
Thank you so much. Thank you so much again, and see you on Wednesday from 5 to 6 for another talk by Dr. Vivek Saraswat, that is on acute on chronic liver failure. Thank you, everyone. Thank you, viewers. Thank you, everyone, and good day to you, all of you. Enjoy your Sunday. Good day. Bye-bye.